Well, it's a pleasure to be here. And it sounds like I missed a really exciting day yesterday just from hearing from Ellen's summary of the discussions that took place. So let me tell you a little bit about the panel for today and introduce the speakers. Before I begin, I want to remind you that the focus here is on research findings and the implications for future research and on the implications for policy and practice. So please keep those thoughts in mind as you listen to these papers being presented. We're going to hold questions until after both papers have been presented and the discussant has talked, but there is paper and there are pens on the table, so please jot down your questions as you think about them and then save them for the end. So let me begin by introducing the different papers. The first paper is Understanding Health Information Seeking Behavior of Adults with Low Literacy, Numeracy, and Problem-Solving Skills. The authors are Iris Feinberg, Daphne Greenberg, and Jan Frijters, who will be presenting virtually. The second paper is Examining Associations Between Adult Health Literacy and Numeracy, Technological Problem-Solving Skills, and Post-Initial Learning in the United States by Esther, Prins, Shannon, Monnat, Carol Clymer, and Blaire Toso. And our discussant this morning is Linda Shohat. So let's begin with Jan and hear what he has to say.
So first of all, I want to both apologize and send my regrets. There was a whole ton of that fluffy stuff that defeats us humans when we try and get around between me and the airport. I was going to turn my computer around and give you all a really nice view of my backyard with snow-covered pines, but it backlit my face and you couldn't actually see me. So you'll be looking at the back of my office. So having said all that, I'm going to carry on with one of the themes that Ellen has summarized from yesterday, and that is the broad theme of the relationship between skill and outcomes. And in this case, the skill that we're going to be talking about is health literacy and health information seeking behaviors. And, sorry, that's the outcome. The skill we'll be talking about is literacy, numeracy, and problem-solving skill. Now, in one of my hats as a researcher, I research motivation for reading, especially among children who are struggling to acquire developmentally normal reading skills. And in my role as a motivation researcher, I know that if you give the goal right off, it is strongly motivational for attention and retention of information. So we're going to lead off the presentation putting our goal right up front and not saving it for some secret ending. And this is our goal, knowing how adults with low literacy, numeracy, and problem-solving skills engage in health information-seeking behavior is important. And why? Because those who actively seek health information from a variety of sources are more likely to be cognitively and psychosocially prepared to engage in, and I should say, their own autonomous medical decision-making and with the medical system. So with that background, I'd like to go over a little bit of the kind of theoretical terms, the past research, and a little bit of the background to actually get into the PIAAC data that we looked at. So here's our outcome. Health literacy and health information seeking behaviors. The critical concept and the sort of organizing concept that we had for our study was the idea of patient-centered care. And this is the idea that you have really two actors in a health situation. One, you have patients who need to have enough capacity to make decisions. And two, you have healthcare professionals and you have the healthcare system who need to satisfy the requirements of patient-centered care. They need to work at the level of the patients who have the health concerns. So working together to making decisions about health care and health management of illnesses and sicknesses, requires both of these elements, and that's what the focus will be. The complex and situational demands of health literacy If we look and jump ahead a little bit to the policy implications of the findings, and that is, how can the healthcare system be utilized most efficiently within the context of patient-centered care? Health literacy is critical to efficiency of that system. If you look at the 4 or 5 biggest inefficiencies in the healthcare system right now, they are compliance, hospital readmissions, over-testing, and unnecessary emergency visits emerged as the biggest inefficiency. And if you draw a connection across all of those inefficiencies, you can see that communication of health information is absolutely critical to that. If we move down to seeking information and the idea that health information seeking is sort of the first step, or you could almost regard it as a diagnostic step in using health information. If you don't actually go out and seek information, you're likely not to use it. If you can't seek information, you can't use it. It may be diagnostic of whether there is functional health literacy actually happening. So if we switch down from the outcome to the skill part of the equation, we focused on literacy, numeracy, and problem solving. And with the discussion that I just sort of offered you about health information seeking behaviors, you're probably going to sit there and ask yourself, well, surely if health information seeking behaviors are so important to both patient-centered care and efficiencies within the system, surely people have looked at this. And the answer is yes, and I'll present a little bit of the research of how people have looked at this. But where it has not been looked at is with individuals who have challenges in literacy, challenges in numeracy, and challenged in problem solving. So that's why our focus is going to be on individuals who have challenges in these 3 areas. Using numbers for health is absolutely critical in patient-centered care. If you just think of a few examples of where numbers, in addition to the skills you would expect, reading and writing, if you think about a patient presented with medical statistics, you're about to go into surgery, and the surgeon says to you, now you have to be aware that there is a 35% chance of complications. A number has been thrown at you. How do you understand a medical statistic? How do you understand probabilities? Dosages of drugs would be a more obvious example. Preventative applications such as daily nutritional values that you see on a label of a food product or that you see in a pamphlet given to you by a health professional. And the challenges of digital literacy are especially poignant because digital literacy, because of the structure of the internet, because of the structure of multimedia information, by its very nature combines literacy skills with numeracy skills and with problem-solving skills. So this is the background. Here are the skills. Here are the outcomes we're going to look at. And let's switch, see if I can advance the slide, to our actual research questions. We have 2, and I'm going to divide them into a largely exploratory question and a largely descriptive question. And research question 1 is the one that I would describe as descriptive. And in looking at what sources people who have below average literacy, numeracy, and problem-solving skills, what sources they use, we're going to look at overall level of seeking behavior, but we're also going to look a little bit at differences among the different types of literacy challenges. And the second question, we're going to look at health information seeking behaviors as an explanatory and exploratory. What predicts who will search for health information and how they will search? If we go into the PIAAC data set and the variables we used, our dependent variable was seeking of health information from print media, internet, radio and TV, family, friends, and coworkers, so social sources, and health professionals. Health status is another predictor that we used. And in terms of health status, the past research has shown that not having a current illness is actually positively associated with health information seeking behavior and is an index of personal health engagement. The use of preventative health measures, seeking intervention before illness could be argued to be diagnostic of the level of health literacy that exists. Past research has shown, in terms of background information, in terms of non-cognitive variables, that women tend to interact with the healthcare system more than men. Often women will interact with the healthcare system, past research has shown, for men. Age has been previously associated with the use of preventative measures and with health and sickness management behaviors. And race has also been associated with health information seeking behaviors. Caucasians and Asians' status is associated with higher health information seeking generally. The final non-cognitive modifiable factor that, I missed educational attainment because probably it's a little bit obvious. Lower health and literacy outcomes are simply associated with lower education. I jump forward to the one, of course, that I'm most interested in, which is a modifiable, cognitive and personal factor, and that is facility in the English language, reading, writing, speaking, and understanding spoken language. And just a side note on methodology, the way we manage this variable, because it's a self-reported facility in the English language, we combined those who responded not well and not at all and called that group poor command of the English language or poor self-reported English facility, and we combined well and very well to make a good index. I'll switch to the next slide. Here's our sample. We took an exclusive approach such that we only included individuals if they were low, and you can see the levels that were regarded as low, that they were low on literacy, numeracy, and problem solving. The advantage of this, of course, is that we have a nice, homogeneous, but high at-risk group. The disadvantage, of course, is that our ability to look at different predictors of literacy, numeracy, and problem solving separately is a little bit hampered. The other note, and just listening to past presentations made it really clear to me that when you chop up a sample like this, especially based on a skill-based factor, we are reducing our variance. We have restricted the variance in literacy skills to the lowest group. And when you constrain variance, all kinds of things happen, both in terms of the generalizability of your results, but also in terms of looking at broader dynamics. So we'll keep that caveat in mind. And jump straight to results. Now, I have 2 results slides, and they have a lot of information in them. And what I want to do is walk through a few of the key findings that you see reflected in the slides. So for this one, what I'll do is first draw your attention to the blue bars. And if you look at utilization of radio and TV sources of health information, you can see that the overall rate, and this is to answer research question 1, is an 80% rate. I mean, people use radio and TV for health information. Now, there's 2 ways to read that. One is the overall statistic, but the other is to say, at some point, everybody has the radio or TV on. And at some point, everybody's going to hear some health information. So we're taking the base rate of 80% as full utilization of that particular source of information. If you contrast that with print media, you can see that a drop in that base rate indicates perhaps not total saturation of that source of health information. And you can see that print media is actually the most consistently lowest used source of health information across our sample. An interesting contrast is when you look at healthcare professionals. And you see that there actually is a distinction between literacy, numeracy, and problem-solving challenged individuals, in that literacy-challenged individuals seem to, and I would, again, I'm offering probably an interpretation that goes beyond the data, avoid healthcare professionals when it comes to accessing health information. This is consistent with past research on struggling readers and the avoidance of any situation that would put their struggles with reading out in the forefront. If we switch to the internet, the pattern with the internet usage, and that's the yellow bars, is that there is low usage of the internet, especially for literacy-challenged individuals and numeracy-challenged individuals. The internet has really intense demands in terms of literacy skills because it is a print-mediated media, and in terms of numeracy skills. And if you think back to the health information sites that you may have visited, what a healthcare provider is going to say is, oh goody, I have limitless ability to present a lot of text and a lot of numbers. And that degree of saturation of information actually can work counter to the interests of someone who has literacy and numeracy challenges. And then finally, if you look at what color are they for you? The gray bars. You can see an interesting pattern that I would call compensatory for people with literacy problems. And if you look at the literacy group, they are approaching saturation for use of that health information source. And in contrast to those who have numeracy and problem solving, almost as a way of compensating for deficiencies in accessing print-based information, people with literacy problems rely more on social sources of health information. So that's really, I'm cognizant of the time, so a brief snapshot of the overall rates of usage of different types of health information. If we switch to the next slide, which there may be a delay. There we are. And that switches to our research question 2. Again, a very complicated slide in terms of our results. Obviously, this is just a teaser for you all to read our report, which goes through in very careful detail all these results. But one way to read this table, and I'll kind of present it to you this way, is to read the rows and then to read the columns. And if you look at the rows, and if I focus on the gender row, if you look print media, internet, radio, TV, and health professionals, females or being female is associated with a greater usage of those sources of health information. Health status and preventative measures, having good health is associated with higher usage of every health information source. Also using preventative measures. Now, I didn't actually go over this variable, but preventative measures are things like getting your flu shot, getting a mammogram, having a prostate exam, taking a multivitamin, for example. All these things have been associated in the past with health information seeking behaviors, and our study replicates this. Where you get into some unique findings of our study is to take a look at education, and having a high school diploma is associated with higher use of print media and higher use of that print-constrained media, the internet. Having good facility in reading English and writing English is associated with print media, and both of them with the internet, and using health information from those sources. And you can see a picture whereby print media and the internet, which are both the most dense and useful sources of health information, are also the most cognitively and structurally, in terms of a person's demographics and education, demanding sources of health information. The other way to read this chart is to look down the columns. And when you look down the columns, it's a more person-centered
perspective, because you can look at internet usage, internet health information source usage, and really develop a profile of the kind of person who uses health information on the internet. That person tends to be female, tends to be younger, tends to be Hispanic or Asian status, tends to have a high school diploma, is of good health, uses preventative measures, and is good at writing and reading English. The message here, of course, is one of the rich getting richer. Someone who can use the richest, most demanding source of health information is the person who tends to use it. And all of these factors are associated with better health outcomes. In contrast, if you read down the column of the kind of person who accesses health information via their health professional, that person tends to be female but tends to be older, tends to be of a black racial status, tends to have good health, uses preventative measures, and has good writing skills. Now, this is one of the ambiguous findings that we have, that writing skills are associated with health professionals. But you can see how the policy implications for the structure and nature of health communications in relation to particular demographics can emerge from this study. So I will switch to our implications slides. And I'll try to switch to our implication slides. There we go. So our key findings. Those who seek health information are more likely to report better health. Again, rich get richer. Participants use multiple sources of health information. Oral sources are generally used more frequently than written sources, and oral sources are used by different people than written sources. And the one sort of confusing finding or suggestive of the need for future research, those who report a higher facility in writing are more likely to use health professionals and the internet. And we'll switch to future directions. One thing we didn't look at is native language status. How does this affect health information seeking behavior? It is part of public policy and is part of legislation that health information has to be provided in the language of use for a particular person. But by necessity, this is a budget-constrained piece of legislation. There's only so much money to produce health information fully in different languages. How do individuals actually use the information they acquire? Our health information seeking really is a proxy or a first step toward full utilization and ultimate link to health outcomes. And what are the impact of writing skills is another compelling question to look at. The most compelling policy implication, in addition to the different demographics and how they use different sources of health information, to me the most compelling policy implication is that facility in written and spoken English is readily modifiable. If someone has a high school diploma, they have a high school diploma. If someone doesn't have a high school diploma, there can often be immense barriers to getting them a high school diploma. Whereas to improve the facility in spoken and written English is much more modifiable. Funding constraint, of course, but it speaks to the cost effectiveness of adult basic education funding, that it can have a ricochet effect beyond structural issues such as your age, such as your race, such as whether or not you have a high school diploma. It can have a ricochet effect on health information seeking and ultimately on health outcomes. Low literacy, numeracy, and problem solving are equivalent in importance across types of access of health information, and this has implications for the content and the curricula of adult basic education. I think that's my last slide, and I probably went over, so I apologize. But thank you for your attention, and I'll be staying online for the next talk and for the discussion.
think you'll find that our paper both extends and complicates some of the previous papers that we've heard yesterday and today. All right, so our study is situated in research on the social determinants of health. And this body of literature looks at how economic and social opportunities and resources influence adults' health status. So the vast majority of the literature in this area has looked at the ways that formal education is related to health, specifically formal educational attainment. So by contrast, we were interested in looking at whether the skills in literacy, numeracy, and technological problem solving were associated with health and how, and also whether post-initial learning was associated with health. And we're using the OECD term, which refers to participation in formal and non-formal education after the highest degree completed. So we could also use a term like adult education and training, etc. So we have two sets of research questions that run parallel to each other. The first has to do with literacy, numeracy, and PSTRE skills. And yesterday, Margaret introduced the acronym POSTER. Those of you who speak Spanish may notice that we're just one letter away from postre, or dessert. So I would like to introduce that as a friendly amendment. So our first question was, are literacy, numeracy, and technological problem-solving skills associated with self-rated health after controlling for various socio-demographic characteristics? Second, does the relationship between skills in these areas and self-rated health vary across racial ethnic groups? And it was important to examine this because the research on formal educational attainment shows that in particular African Americans at increasing levels of education receive fewer health benefits compared to their white counterparts. And similarly, does this relationship vary across levels of formal educational attainment? So do people at lower or higher levels of educational attainment accrue the same kinds of health rewards from developing these skills? Our second set of questions had to do with participation in post-initial learning. And so first of all, which types of post-initial learning activities are most strongly associated with self-rated health after controlling for various demographic characteristics? And which types of post-initial learning matter most for the health statuses of different racial ethnic groups? Oh, okay. And lastly, which types of post-initial learning matter most for health statuses of people at different levels of formal educational attainment? So our dependent variable was adult self-rated health, which many studies have shown is a very robust and strong predictor of all kinds of health outcomes. We had a number of independent variables. So for research question 1, it was literacy, numeracy, and PSTRE, or POSTRE scores. For research question 2, it was participation in 5 kinds of post-initial learning during the previous 12 months. Participation in distance education, on-the-job training, seminars or workshops, courses or private lessons, and formal education. We again had 2 moderators. One was race ethnicity, and you can see our 5 racial ethnic groups here. Other race included Native Hawaiian, Pacific Islander, American Indian, and indigenous populations. And then formal educational attainment, we had 6 categories, all the way from did not complete high school, which was the reference group, all the way to master's degree or higher. We controlled for a variety of demographic variables that have been shown to influence adult health status. So this helps us to really determine how these skills and adult learning activities are or are not related to health. So our analytic approach included ordinal logistic regression models. In the first models, they were unadjusted, so without any control variables. Then we introduced all of our control variables, and we also had interaction models for our 2 moderator variables. We used PIAAC tools and PIAAC reg and stata to account for plausible values, and the samples were weighted. Okay, so for research question 1, these are the unadjusted results without any control variables. Oh, and I'm sorry that got cut off at the end. I don't know if there's anything I can do about that. Okay. So what we found is that literacy scores for people in the good, fair, and poor health categories were significantly low, that should be higher. No, that's right. Were significantly lower than in the excellent and very good categories. And excellent and very good, you'll see, are very similar. Similar pattern for numeracy, that numeracy scores for good, fair, and poor were significantly lower than excellent and very good health categories. And the same kind of pattern for PSTRE scores. Again, good, fair, poor, significantly lower scores than excellent and very good. Okay, so what happens when we introduce control variables? So this is for the unadjusted model. So what this shows is that a 10-point increase on the literacy scale was associated with 10.5% greater odds of being in a better health category. For numeracy, it was 8.5% greater odds, and for PSTRE, it was 7.6% greater odds. When we introduce the control variables, you see a very different pattern. So numeracy and PSTRE are no longer significant. Only literacy is significantly associated with adult health status. And so for a 10-point increase on the literacy scale, respondents had about 2.5% greater odds of reporting a better health category. Okay, it's important to realize here that so literacy had a 2.6% greater odds, but many of the control variables that we looked at had a much stronger association with health than did literacy. And so this shows some of those. So you'll see under educational attainment, having a master's degree or higher meant that they were 212% more likely to report a better self-rated health category. Bachelor's degree is very high. The ones in red were basically the ones that were highest. And my last one got cut off at the bottom here. I believe the bottom one was health insurance status, and I think that was 5%. So having health insurance was 5%. Okay, so are associations between health and these three skills, do they vary by race, ethnicity, or formal educational attainment? The answer is mostly no, but there are a few wrinkles. So PSTRE scores are positively associated with health only for people with a master's degree or more, but the effect size is very small. So what this means is that if you have a master's degree or higher, you're accruing health benefits from higher problem-solving skills. If you have anything less than a master's degree, you're not seeing health benefits from that after controlling for all of the background characteristics. Also, people from all racial, ethnic, and formal educational attainment groups accrue equal health benefits from literacy after accounting for all of the background characteristics. So this means there are no diminishing returns for racial ethnic minorities. Regardless of your race ethnicity, you're getting the same kinds of benefits from literacy skills. Numeracy, though, was not associated with health for any racial ethnic group or any formal educational attainment level after all of our background characteristics. So research question 2. Here we have participation in post-initial learning, and so workplace training was by far the most common activity among the respondents, followed by seminars and workshops. And in the unadjusted model, we found that 4 of the 5 adult learning activities were associated with better health. So distance education is the one that was not associated. However, after introducing all of the control variables, only one post-initial learning activity was still significant, and that was courses or private lessons. So those who participated in this activity had 59% greater odds of reporting better health than those who did not participate. Okay, and again, we're looking at the moderator variables of race, ethnicity, and formal educational attainment, and whether those moderate these relationships at all. Again, the answer is mostly no. However, participation in formal education was a weaker predictor of health with people who had a high school diploma than for those with less than a high school degree. And again, respondents from all racial ethnic groups and educational attainment levels gain equal health rewards from participating in courses or private lessons. So this is good news in terms of equity across educational attainment and race ethnicity. So areas for future research. We were very surprised to see that numeracy and PIAAC scores were less strongly related to health than literacy, and so that's definitely an important area for future research to understand why that's the case, especially given prior research that emphasizes like some of the examples that the previous presenter gave about all of the ways that numeracy and technological problem solving are involved in health. But according to this data set, there is no significant association between those two skills and adult self-rated health status after all of the control variables. Secondly, why is it that only the most highly educated are accruing health benefits from higher PSTRE scores? And similarly, what is preventing people with less than a master's degree from converting or leveraging those skills into health benefits? So what are the blockages that aren't allowing that to take place? One hypothesis that I've seen in some of the literature is that this could be due to a vicious cycle of digital exclusion, whereby people who don't have access to the internet or smartphones in the first place are therefore less able to use those and less able to use those to benefit their health. So that would be something to investigate. Unfortunately, the PIAAC doesn't tell us anything about the content of the courses or private lessons that people are participating in. So that would be an area for future qualitative and or quantitative research to find out what are these courses, and in addition to the content, how does participation in these activities improve health? So what are the pathways? Is it because of the social networks, the cognitive or other kinds of skills that they're developing, psychosocial or material resources? So what are the mechanisms that these activities are associated with better health? In terms of PIAAC analyses, there are several directions that we could go with this research. One is to substitute nativity for race or ethnicity. So do these skills and adult learning activities matter more for U.S. or foreign-born adults, or are they gaining equal health benefits from these skills and learning activities? Do our findings pertain to other countries? We wouldn't be able to use race ethnicity, but we could use nativity. And we found that merely attending formal education courses does not predict better health. However, it could be the case that respondents who actually complete their formal education course or complete a full year of additional study, that they might report better health. So that would be something to investigate in the future. Also, we found that employment status, specifically being retired or disabled, eliminated the significance of participating in formal education. So that was the main reason why formal education was not associated with better health. So if we only look at working age adults in the PIAAC database, do those who pursue formal education report better health compared to those who do not? We could also analyze healthcare utilization as an outcome of interest. So do limited skills impede people from using healthcare services even after accounting for their background traits? And the US PIAAC National Supplement study will include unemployed, younger, and older adults, among others. And so particularly with changes via the Affordable Care Act, it would be interesting to look longitudinally at how access to health insurance might change relationships between health indicators, basic skills, and post-initial learning. I'll close with a few implications for policy and practice. So what our analyses show is that literacy does matter for improving self-rated health, and this is for all racial, ethnic, and educational attainment groups. So that is the good news. The complication here is that, or I should add, literacy is also more important than numeracy and PSTRE skills. So this points to a need for literacy instruction and ongoing skill development in terms of being able to improve adults' health. However, literacy was not among the strongest predictors of health in our analyses. So there were various control variables that had larger effect sizes, which suggest additional domains or options for policy intervention. Some of those control variables cannot be changed, nativity, age, and so forth, but some of them can. So one of those is increasing college access and attainment, and that is likely to have a multi-generational impact, not only for the person completing college, but also for their children. Expanding ESL instruction, which we've heard from various other papers today, and increasing access to health insurance. So those were the three control variables that are amenable to policy intervention, and that also had a stronger effect size than literacy. The importance of participation in courses and private lessons was also vital for self-rated health. What we found is that Blacks and Hispanics and people with low levels of educational attainment were the least likely to participate in these activities. And so one option would be to increase participation by these groups as a way of helping to improve health. So for example, this chart shows the percentage participating in courses or private lessons, and so Blacks and Hispanics were much less likely to participate. And findings were similar for educational attainment. So in conclusion, we found that literacy and courses or private lessons matter for adults' health status, but we still need to know a lot more about why they matter and the mechanisms by which they are related to adult health. Thank you.
I want to thank Ellen this morning because she actually laid the groundwork for what I wanted to say. This work is extremely important, and one of the things that struck me yesterday and certainly struck me again as I was listening this morning and reading the papers is the extent to which it is validating a great deal of what we already know, and I think we need to take some satisfaction in knowing that. But it also raises a tremendous number of complications, and I think it leads to some challenges before we leave at the end of the day, particularly when we think about implications for policy and practice, because you're not going to go out of here with 100 policy recommendations. Yesterday, John said, distill your message, and as I was thinking about what it was we needed to take away, I was trying to figure out what it was we were going to distill from these that we could take back and use, and that wouldn't necessarily undermine what we're trying to do by overwhelming people. I was also thinking about an issue that was raised yesterday and again today, and I probably want to raise it again in the context of health, that there are no employers in the room. We've repeatedly talked about the need to engage employers, and I think when we talk about the healthcare sector, we also have to talk about people who are running healthcare systems, who in many cases are certainly both the employers and providers who operate the systems that serve the population. They're critical to any initiatives that are undertaken in terms of policy and practice, in addition to whatever happens in the adult education sector, and I think there are two strands of activity. So that's going to lead me back, I guess, to health and health literacy. Neither of these papers, in fact, dealt directly with health literacy. They were both talking about the interaction or intersection between health and literacy, which is very interesting to me as a Canadian because when Canada first began to look at these issues, we looked at it as health and literacy and the intersection. And we only started to talk about health literacy in the early 2000s after the United States had taken that direction a number of years earlier. I actually think we may have been on a better path when we were looking at health and literacy, and that we really need to see how these two mesh. But I do want to pay some attention to that. I also want to draw a little bit on some of my own background work in health and literacy, all of which touches on the two papers this morning. I've worked for about 20 years in health and literacy in addition to literacy in general. And I was one of the people who constructed or authored what's known as the Calgary Charter, which some people in the room may be familiar with and some people may not be familiar with. But it basically was a statement of principles about what principles had to underlie health literacy curricula. And it grew out of an institute somewhat like this one that we ran in 2008 on health literacy in Calgary, which gave it its name, attended by a lot of people from the States and from Canada. And at the end of the day, we recognized that after looking at what was going on in health literacy programs and courses across schools in the United States and Canada, that there was no consistency in courses that were called health literacy courses. And there wasn't any necessary outcome that was common across them. In fact, the majority of them tended to be plain writing courses or communication courses and were not broadly health literacy at all. So we decided that we needed to have some document that defined what the principles should be, and we constructed the Calgary Charter, and it's still being quite widely used. If people are on the various listservs for health literacy here, you'll see that people frequently refer to it. Julie McKinney was actually one of the authors. Andrew Pleasant was another one. Cliff Coleman was another. I was one of them. Irv Rootman, who was very active in health literacy in Canada, was a final one. And my Rossi in Massachusetts was the last of the six. What we ended up with was a document that talked about the need to look at health literacy as an issue that affects individuals and providers, and that you had to look at what needed to happen for individuals, but also what needed to happen for systems. And one of the things that I guess I need to think about in terms of what we've heard today in these papers is what are the implications for individuals, and are we placing too much of the responsibility on individuals? Because in healthcare, a good deal of what has to happen that's going to make really significant differences in the outcomes has to happen in the healthcare system and by providers, and that engagement is absolutely critical. The good news, I think, is that a lot of this research has been done. I mean, the amount of research that has been done in health and literacy in the past 15 years is absolutely incredible. It's grown exponentially in the last 5 years. There are right now in PubMed over 7,000 articles on health and literacy in a variety of areas, whereas in 2010 there were just over 2,000, I think, something like that. So the growth has been enormous. What does it mean in terms of what we heard this morning? Well, I was struck by the first paper when I read it because I'm quite interested in the way people access information. And I also recognized that the authors acknowledged that they only looked at the first stage. They looked at functional literacy. Functional literacy is not enough. Functional literacy is insufficient. Knowing where to go is certainly a first step. The question then is, what do people do with the information they get? Do they understand what they're getting? Can they make critical judgments about it? The whole notion of functional literacy derived, again, from Don Nutbeam in Australia, who coined 3 levels of literacy, health literacy. He called them functional, interactive, and critical. And he talked about them being an absolute precursor to empowerment for individuals, that people needed to be led along these paths in order to be able to participate and take some responsibility and engage with healthcare providers in their own care and in preventive measures. And he was particularly interested in health promotion. So I guess we come back to the question, when you look at only the most minimal level of access, are you actually getting at the questions that you need to be getting at? If these are the numbers of people who have access, what does it mean about taking people to the next stage? And what is it that we need to be doing? And is it the part of individuals to make those accommodations? I mean, I would argue that, in fact, in almost all of these areas, the accommodations need to be made on the part of the system and the providers. And so an awful lot of the training that needs to happen for healthcare providers, and the changes that need to happen, very much like what Ellen talked about today, have to happen inside the healthcare system. So those, oh, sorry, I thought that was, I was going to say we already. I didn't think I'd been talking that long. So, that was certainly very great interest in the media that are being used by people with low literacy, numeracy, and PSTRE, and the distinctions among them. And particularly, I don't think, Jan, you mentioned it this morning, but in your paper, you actually did highlight the fact that print is still incredibly important. And so the idea of making accommodations and simplifying materials is important. But internet is not just about print being transferred to internet. And I was a little bit surprised, I think, even in some of the conversations we were having yesterday about digital literacy, but not acknowledging the complexities of what's going on the internet, because there is way more than print on the internet. There are visual components, there's visual literacy that's required, but there's also an oral component. And so the opportunities are as great as the barriers. I mean, the internet, what's on the web, gives you the opportunity to have people listen to your instructions, to have them watch demonstrations, and these things are already going on. They're already up there. Very, very little. I have no idea how frequently any of the people that you interviewed, or whether you couldn't even get this information actually from PIAAC, which is going to be my next question. Is what people actually did when they went online. Were they just looking at print information? Were they just Googling? Were they actually making critical judgments about who was putting the information up and where it was from? Were they watching demonstrations? Were they listening to something repeated for them? Again, one of the benefits of something on the internet is that A, it can be updated very frequently, and B, people can play it and play it and play it and replay it over and over again without feeling stupid. I mean, I do that all the time. I look at something and say, let me listen to that again. Let me listen to that again. People won't ask a healthcare provider easily to repeat something because they're going to think I'm stupid. In fact, one of the tenets right now in provision is that healthcare providers should use teach-back. Teach-back meaning that you give people an opportunity to explain what they understand they need to do with the information, and then say, maybe it would help me if you showed me again. Not saying, do you understand? Because if you say, do you understand? Everybody says, yes, of course I understand. He's going to think I'm stupid if I don't. So that was interesting to me, the use of the internet and also the opportunity that was there. Family and friends, again, family and friends, we found from a lot of the research we've done that family and friends, particularly with people who have limited skills, are critically important, but so are they critically important in immigrant communities. People trust the people in their own communities. They use them as venues. And so I'm going to go back to one of the points that Ellen raised today. I think Anita yesterday talked about the unobservables and the things we're not getting at when we only look at PIAAC to try to do this kind of analysis, because the complexities of the way people look after their own health, interact with the healthcare system, go way beyond skills. I was also interested in the health-seeking information behavior, because the two authors that you referred to in your paper both happen to be colleagues of mine. They're both professors at McGill. And again, the complexity of health-seeking information behavior is quite overwhelming, and it isn't necessarily predicated primarily on skill. There are an enormous number of other factors. There are anxiety factors. There are trust factors. There are social network factors. There are many, many factors that need to be taken into account. And it's not clear that simply looking at skill and doing this kind of analysis is going to tell us what we need to know. I'm going to flip to the second paper because that one, I have to tell you, really surprised me, right? There were findings in that caused me to step back. Both the findings about who gains effect, the people with master's degrees or more, think, okay, I mean, that might not be surprising. And the fact that literacy is not as strong a predictor as we might have thought. Certainly literacy scores, right, are not as strong a predictor as we might have thought, because I have to tell you that people who are working in this sector right now are constantly using that message. I've heard this repeated over and over. Literacy is the strongest predictor of health status that you can use, that you pay attention to it. Does that mean we need to step back now and rethink that message? Because it's a message that we've been promoting, certainly inside the health system. When we talk to doctors, it's one of the things. We go in with these data, we put them up and say, and we know that literacy is one of the strongest predictors. You caused us at least to step back and question, is this actually the case? Do we need to do further research on this? Do we need to validate it? But we need to be careful about what the messages are that we take forward. I was interested in the extent to which some of these skills or some of the suggestions, certainly from the first group, they were almost totally for adult education, and I think they do have huge implications for adult education. But again, adult education and even our K-12 education needs to have some very profound changes made to it. These are the long term. These are the things that have to happen over a very long period of time. The more immediate, I think, challenges are what can be done inside the systems as they exist today. And again, I want to look at some of the things that are already in place, where at least policy and practice-wise you might want to think about building on those. There's been all the work done at the CDC here on what it takes to be a health literate organization, which talks totally about systems and how organizations need to reorganize themselves and provide leadership and provide training and provide patient-centered care and be sensitive to the needs of their community. Those these principles are already out there. Guides are out there. I think one of the things we need to do is try to make sense of what we've already got. It's not so much what we need to do new. What have we already got that can help us move in the direction we need to go, and then what do we need to add to it, and what additional questions do we need to be asking? Digital, your digital pathways, Steve, I think are absolutely critical for healthcare in the future. More and more and more of what stands as healthcare is getting onto the web. You have electronic records. You say, oh yes, everybody's going to have access to the records. Well, if people have difficulty accessing online, or people have difficulty making sense of what's online, or reading a report of blood tests online, what does that actually mean? We're raising the demands at a level that's unprecedented and leaving behind masses of people. And this includes, by the way, not just people who score at low levels of literacy. One of the papers, I think it was the paper Jan put out, actually had one sentence. I thought one sentence is not enough. It says everybody is challenged by healthcare information. When we did our study in 2003 after the International Adult Literacy Assessment, when you did NALS here, you did your health literacy profile. We also did one in Canada, and ours was much broader than yours. We actually had 193 items on ours, and we ended up with unbelievable amounts of data. And at that point, we found that 60% of Canadians said they didn't understand healthcare information as it was currently being provided to them. 60%. And we went back and used that and said, when this proportion of the population can't make sense of health information, the problem doesn't sit with the individual. The issue sits with the way this is being done. And so we take it back to you and throw it back. And I think that a lot of the mechanisms and frameworks are already in place to do that. I think in healthcare and health literacy, it's one of the areas that's probably most developed, and there's a lot of hope. Universal precaution is something that has been promoted very widely here across countries. And universal precaution says you don't adapt for people with this level of literacy and this level of PSTRE. You do this for everybody, and you assume that when you make things accessible for everybody, you're going to be helping people at the lowest levels, and then you do other things on a one-to-one basis for people who may not have the skills you need. Again, I'm going to move to the digital and say I envisage a world where you will eventually be able to ask people how they like to learn, how they learn best, and accommodate them by providing the information for them in the format that they want and at the level that they want. And you'll be able to do that because you've got the ability in your own, in your own area to do that. It's still down the road, and there's a long way to go before we get there, but maybe not as long way as we think. So I guess overall, I'm really heartened to see this kind of work being done. I'm also a little bit, I'm somewhat fearful. I'm fearful about the message that we're going to distill. I would be very worried, for example, if somebody pulled some of the pieces out of context of your paper and then said, oh, look at this. Literacy really only accounts for this much. Why should we be doing this much? I think we have to be very careful about looking at a very broad paper, a broad perspective, a broad framework. I think we also need to be very careful about paying too much attention to one data set and using it for too much policy direction. I think we've always used the verb inform policy, and for me what this needs to be doing is informing policy and informing practice, but not actually, you say we're doing this because it conforms to PIAAC, right? This is going to match PIAAC. I think this is something that was done to some extent, not in the States. It was certainly done in our country in the past, and it was a dangerous road to follow. It's not one you want to take. I think the issue is, how does this information, how can it inform, and how can you distill it so you're going to get the best possible uptake? And how are you going to engage the people who need to be doing it? Because a lot of them aren't in this room. The people who are in this room are engaged. How are you going to engage the people? What are the messages? Partly, it has to be by speaking their language. There is a language issue here. There's a translation issue here. They don't speak the same research language. They don't speak the language. They wouldn't come and sit here for a day and a half. No, they wouldn't. They wouldn't. Okay. You really, I mean, I've actually written a health literacy course online for doctors in Canada, an introduction to health literacy, and it was one of the most chastening experiences of my life. Okay. I mean, I was in learning mode for over a year, but wow. Both because I had to learn how to write for the web, but I also needed to understand what doctors were willing to hear, what they were willing to take up, and sometimes rejected. I'd say, I recommend that you look at this. And they, we don't want that. And you say, but this is really important for this reason. We're not interested in it. One of the things that was very positive is that we did the first of those curricula in 2010, and in 2012 it had to be reaccredited. In 2010, I had said there needed to be a module on the web, and they said, no, they don't want it. And I said, it's critically important. We don't want it. Put a paragraph in. So we put a paragraph in. In 2012, the evaluators came back and said, in the new module, we'd like to have a whole section on the web. We had also said cultural competence needed to be in there. No, we don't want it. In the new one, they said, put in something about how to work with our minority populations and immigrants and seniors. And so that says to me that over 2 years, thank you, there was growth. And it gives me hope that if we find the right way of engaging with the people who have to take this forward, we can do something of great value for the future. So, thank you.
So now we're going to open this up for questions from the audience. We hope that you've written things down. Let's start over here.
Hi, Steve Reeder from Portland State. Thanks to both sets of authors for your papers. They're very interesting. I have two sort of related questions, and they probably apply differently to the two papers, but one is just a precautionary note or question. I couldn't tell in the paper that Esther did. When you're looking at, the poster proficiency, of course, unlike numeracy and proficiency, as I detailed yesterday, you've truncated out a large part of the population, particularly a low-skilled population, who weren't given the computer-based assessment for various reasons. And so I think it's very important to keep that in mind. And you may well have looked at a similar subpopulation and looking at literacy and numeracy in those models. But so that's the question. Were you comparing different measures on the same populations or on different populations? But a more general point was, and this was different in my findings yesterday about health status. If you remember, I also found no effect of poster proficiency on health status with lots of controls involved. But the measure of practice in the home, ICT practices in the home, was a strong predictor in the same model with or without poster proficiency. So it's important, as Linda was saying, we don't overgeneralize our interpretation of specific findings, because I believe ICT literacy, if it's defined as what people are doing on an everyday basis with technology, is very predictive of health status. And so that's an important point, I think. And that would apply also looking at practices with literacy and with numeracy also.
Hi, David Miller from AIR. Linda, I'll just pick up on your comment regarding that it was surprising to you that literacy didn't seem to be a strong predictor of health. But I think you have to really think about the analysis that they did. It was kind of atypical. Usually people use literacy as a dependent variable, educational attainment as a predictor, but you actually use both literacy and educational attainment as predictors in the regression. So in that sense, the results really are not that surprising, and you have to keep it in that context, that literacy and educational attainment are very highly correlated. I mean, the single biggest way of increasing people's literacy is through more education. So statistically, when you put both of those variables into a regression, then it's not surprising really that one of them is going to wash out. But I mean, going back to your original slide where you showed it, clearly people who had higher literacy scores did tend to report higher health. You didn't actually show this slide, but if you also looked at the educational attainment, you would have seen essentially the same relationship. So as I said, both of those variables are highly correlated. So don't worry, I don't think you do have to change your message. I still think the message really is there that literacy is such an important component.
Yeah, this is Don Liu from the University of Connecticut. I'd just like to reiterate Stephen's comment that poster should not be confused for one's ability to read and use information on the internet. The actual tasks, if you look at them, they're very heavily spreadsheet format dependent. The tasks require a lot of spreadsheet knowledge and not very much knowledge about critically evaluating the source of information or online reading. And certainly it doesn't include locating information, as I mentioned yesterday. So it shouldn't be confused as a proxy for reading on the internet and using online information.
Yeah, and I don't think we, in our paper or intended to use it as a proxy for that. So just to go back to Steve Reeder's comment, yeah, the point is very well taken. I absolutely agree that the ways that people use ICT skills, literacy, numeracy, et cetera, in their everyday lives go, well beyond and should not be conflated with their scores on these kinds of standardized assessments. So, that's something I'm often telling, students in my graduate classes, and, talking to Carol yesterday that, if we had been administered the PIAAC before starting this, I'm assuming our, scores would have run the gamut, and we would have come up with all sorts of reasons why those scores don't actually, reflect what we are able to do in our everyday lives. So yeah, there are certainly all sorts of ways that people may be, using the internet or their literacy and numeracy skills to deal with health that, may not be captured by their actual scores on the scales.
Mm-hmm. And that's consistent with our descriptive findings on utilization of the internet as a source of health information, in that the group of individuals who are low on problem solving, or to be low on problem solving skills, did not constrain utilizing the internet as a source of health information. I think they were at 79%, which is almost, what we were taking as saturation. And I'll back up a few comments to Steve's comment about the sort of biasing in the sample and the net result of not including individuals who failed that computer proficiency test. The way we did our sampling, it has a kind of additional effect. I mean, we have individuals who are low on literacy, numeracy, problem solving, and who failed that basic proficiency test. So what the effect of that on our sample is to essentially make it an even more high risk, even more low skill group. But yeah, the definite constraint on interpretation.
I have a question for Jan on the phone. Can you hear me okay? It's Margaret Patterson. In one of your slides, you talked about the high use of the internet to gain health information. It was that yellow bar. And when we looked at the group of adults that had the low poster skills, it seemed like they had a very high use of the internet. That seems a little counterintuitive to me. Can you help us understand that?
Yeah, it does. And that's sort of what I was saying to follow up on the previous comment, which is, I don't know much about the poster measure, but from that previous comment, it seems to indicate that it's not really tapping the same skills that you would need to utilize health information on the internet. They seem to be use of health information on the internet seems to be much more constrained by literacy and numeracy, and that relates to the content of the internet. Should poster actually tap utilization and integration of information, interpretation of information, then I would imagine then it should be related to lower use of the internet as a source of health information. So I think there's a mismatch of constructs there, and that's why it doesn't really show up.
Ron Pugsley, I would like some further explanation from you about the low level, that literacy does not a strong predictor of health. I go back, I want to pick up on what Linda said. I go back to a conference that the Department of Education held on health and literacy. It was about 1998. And it focused on two basic aspects. One was low-level literacy, and we went into what does that mean? What does that mean in terms of abilities, of individuals' ability to read as he or she shops and makes decisions? So the reading aspect was very critical here. It had to do with the message that was being sent to them. But then there was another aspect of this conference that I haven't heard about here that I hope we have more further research into. It was the cost of low-level literacy in health. The only cost-benefit analysis that I've ever really seen in adult education has come from the health field. And it was back then. And the cost of low-level literacy to the health industry was staggering. Namely, the individuals that are last into the hospital are those with the lowest literacy, and those that stay the longest are low-level literacy. So this is old research, but it's again coming back to the point that there's a connection there that I think is very real. And I guess I feel a little bit like Linda said. I was kind of struck by what was said here or being emphasized, or it wasn't being emphasized. I think I understand it better by what was said subsequently and putting the information in its context, but it's an important thing. I'd like some further information from the panel maybe on this one point.
Before letting Shannon address the question, I just want to make one important point that a lot of the previous studies on this topic have not controlled for background characteristics. So our slide showed very clearly that literacy, numeracy, and PSTRE had strong associations with health before introducing background characteristics. But what we found is that once you control for age, their insurance status, their educational attainment, their parents' education, their marital status, number of children in the household, English language, nativity, etc., the influence of literacy is fairly small. So it's in the unadjusted models without the control variables, it's all those other things that are making literacy seem to be much more important. So it's still important, but there are a lot of other things going on that you have to control for to see what the unique contribution of literacy is to health status.
Yes, if you think about the unadjusted models, right, I think the odds ratio is something like, I don't know, 1.13, which means that a 10-point increase in the literacy score was associated with about a 13% increase in the odds of being in a better health category. That's a pretty large effect size. But when we think about what leads people to be more or less literate, there are characteristics of our lives that begin at very early stages that impact our literacy, right? And so one of the things that we controlled for was parental educational attainment. So we know that people who have parents with higher levels of education are more likely to be more literate themselves. So once you control for those sorts of characteristics, what's left over for literacy itself is very, very low. If you think about it in terms of among like groups of people, among people of the same level of education, among people of the same race, ethnicity, among people of the same age group, what impact does literacy have on their health? Then that impact is really low. So in terms of policy implications, one thing we might think about is we know literacy is important and we know the groups of people who are likely to be less literate. Therefore, we focus our attention on those groups of people, low educational attainment, parents with low educational attainment, people with low English learning skills, people with disability statuses. Those are the groups for which improving their literacy is likely to have the best impact on their health.
Vivika Halabu, Estonian Ministry of Education and Research. I do have one minor comment about, I think that it was Esther's presentation. First of all, thanks for the interesting presentation, but I have a slight hesitation about the variable post-initial education and the type of this. If I remember correctly, then in PIAAC people were first asked, did they participate in any trainings? Then it was asked, if yes, then in how many different ones? And all the following questions, which were more detailed, they were only about the most recent one. And I think it adds some noise about this variable. And I just think that maybe it should be like marked somewhere or taken into account that people might have attended different type of courses as well during within 12 past months before the survey. But if I remember it correctly, then you can correct me.
I'm a little confused in the question. Do you mean they might have participated in both online education and on-the-job training?
Yeah, exactly.
So one of the things that we did before we separated out the different types of post-initial learning was just create a combined variable to see if participating in more of these sorts of things, a count variable essentially, was associated with better health. And so that one showed no different patterns. It wasn't it wasn't any more interesting, in other words, than looking at them separately. And our research question was, which type of post-initial learning would be most strongly associated with health? And so it was really important for us to pick out which types of activities, specific types of activities, were most strongly associated. But that's not to say that people who participated in one type of thing weren't included in another type of analysis, that they also participated in that. And so people could have participated in both on-the-job training and distance education, and they would both be accounted for in those separate models.
Just a word of caution about throwing away the small literacy effect. We did some cost-benefit analysis in Canada where we linked literacy gains to the propensity to use a hospital visit or visit a doctor. And because those things are such high value utilization in the system, you get to really big numbers even with that small effect. And so if anybody's thinking about reducing healthcare costs, boy, you should pay attention.
Yeah, so that would be interesting to look at with the future research looking at healthcare utilization. And I want to reiterate that we're not negating the importance of literacy. I mean, our studies showed that literacy does matter. There are also other things that matter just as much or more. So it's a both and, not an either or.
I just wanted to pile on here to make sure we don't try to translate effect sizes from these cross-sectional analyses into what might be observed longitudinally and experimentally, in interventions such as the one that Scott described. And I think when one looks across a wide number of studies, it's fairly clear that it's certainly worth conducting those studies to answer the question. We can't obviously get the causality and shouldn't interpret effect sizes as likelihoods of having valuable impacts from interventions to raise literacy scores.